are nurses in Sonoma State University's BSN program. For our Capstone project, we reviewed the latest literature on depression screening tools used in hospice care. This is a presentation of our latest findings and recommendations for nurses. In this presentation, we'll look at the prevalence and impact of depression, the challenges in diagnosis, validated screening tools, and recommendations for nurses. According to the World Health Organization, 5% of the general population suffers from depression. This percentage is dramatically higher in palliative care. According to a recent review published in the Journal of Palliative Medicine, prevalence is estimated it ranges from 24 to 70%. Also, nearly half of all home hospice patients experience moderate to severe symptoms of anxiety and/or depression in the last week of life. Psychological distress should not be considered a normal event. While emotional distress is natural and expected in individuals experiencing serious illness and confronting the end of their lives, there's a difference between a normal reaction and a more serious psychiatric disorder such as major depression. Sadness and grief are appropriate responses to advanced disease and dying, but feelings of hopelessness, helplessness, worthlessness, guilt, lack of pleasure, and suicidal ideation, even if mild or passive, are indicative of depression. Depression has a significant impact on quality of life for hospice patients. It impairs the capacity for pleasure, meaning, connection, and doing the emotional work of saying goodbye. It amplifies pain. It increases the risk of suicide. And caregiving research has shown that patient mental health is a significant correlate of caregiver burden ratings. It's also predictive of complicated grief after death. When a patient suffers, the whole family suffers. Depressive syndromes are a major cause of suffering in palliative medicine, yet they are widely misunderstood, underdiagnosed, and undertreated. Recognizing depression in this population is clinically challenging for many reasons: physical and cognitive limitations, invalid criteria, cultural differences, and a lack of official guidelines causes confusion and inaccuracy in diagnoses. Gold standard of depression screening is a clinical interview, but many hospice patients are unable to participate because of physical or functional limitations. They are often too weak to complete a questionnaire. Cognitive impairments such as dementia or delirium also affect their ability to communicate or understand the questions asked. In these cases, providers are forced to rely on caregivers, but proxies often have difficulty in identifying psychological symptoms and are unable to provide clinicians with accurate reports. Diagnostic and Statistical Manual of Mental Disorders, the DSM-5, has two categories for symptoms of depression: affective cognitive and somatic. However, the somatic symptoms, fatigue, anorexia, and insomnia, have considerable overlap with the somatic symptoms from disease, treatment, and functional decline. For an accurate assessment of depression in the hospice population, the somatic symptoms need to be excluded from screening. Culture can have an impact on the expression of depression because of stigma. Studies with Black patients with advanced cancer show that words describing mental illness, such as depression, are not typically verbalized. This can lead to inaccurate scores in screening. For accuracy, screening tools need to be customized not only to the patient's native language, but to their culture. Finally, there is a lack of research and guidelines on depression screening in palliative care, and in particularly hospice populations. The strongest focus of research in this population is on pain management. Research on diagnosing and treating mental health disorders in this population has been scant. In comparison, most research on depression in the palliative care population has been limited to terminal cancer patients. The National Comprehensive Cancer Network, the NCCN, is one of the few organizations to actually recommend depression screening tools and guidelines for terminally ill patients. For all the reasons we've mentioned, traditional structured clinical interviews according to DSM-5 criteria are not always practical or accurate for hospice patients. However, there are several validated depression screening tools that are appropriate. There are standard screenings that can be completed within 5 to 10 minutes, and there are also ultra-short screenings that can be done in less than 1 minute. There are several validated self-assessment tools used specifically in palliative care populations, which have been tested and verified in multiple languages. They are effective in capturing clinically significant states of anxiety and depression, and all these listed below can be administered within 5 to 10 minutes. The most frequently used mood scale in cancer and palliative settings is the Hospital Anxiety and Depression Scale, the HADS. It consists of 14 Likert scale questions. The Patient Health Questionnaire 9, or the PHQ-9, is also widely used and consists of 9 Likert scale items. The Edmonton Symptom Assessment Scale, the ESAS, also has 9 Likert scale questions. Finally, the Brief Edinburgh Depression Scale, or the BEDS, is a 6-item scale. It can be administered within 3 minutes. Links for accessing the HADS and the PHQ-9 are provided below. Quick and easy tools that require little or no training are ideal for busy hospice nurses. With these tools, screening can take less than a single minute. The PHQ-2 is a shortened version of the Patient Health Questionnaire. It highlights the 2 core symptoms of depression, anhedonia, and decreased mood. Like the PHQ-9, these are Likert scale questions. A score of 3 or greater is considered positive and a trigger for further evaluation. Even simpler than the PHQ-2 is the 2 single items tool. It consists of 2 yes or no questions. Are you depressed? And have you lost interest or pleasure in doing things? A single response of yes is a trigger for further evaluation and intervention. The goal of hospice is to help patients live as fully and comfortably as possible. Considering the prevalence of depression among the hospice population and its impact on quality of life for both patient and caregivers, it's important for nurses to be familiar with validated depression screening tools. Nurses are better positioned than any team member to administer simple screenings on a regular basis. If a nurse catches symptoms of depression, the social worker and physician can be alerted to the need for further assessment and appropriate interventions. The NCCN recommends using an ultra-short tool at every visit or at least at any change in patient status. By performing a 1-minute screening at regular intervals, a nurse can promptly identify a patient at risk and advocate for intervention. This simple action has the potential to dramatically improve outcomes for patient and family distress. Here is a list of our references. We hope this presentation was helpful. We thank you for listening and also for any feedback that you're willing to provide.